trial, METRIC for short. This is a trial which is funded by NIHR, or National Institutes for Health, in their Health Technology Assessment Programme. Professor Richard Holt is from the University of Southampton, who will speak first, and then Dr. Paul French from Pennine Care NHS Foundation Trust. So first of all, I'm going to hand over to Professor Richard Holt to talk more about the rationale for this study. And I would just like to mention, in terms of wording, I know from working with Equally Well UK that people prefer perhaps using healthy weight management and terms such as, or unhealthy weight, instead of words such as obesity, which I will use in my when I'm talking. It may be necessary for the speakers to use the word obesity in what they are to demonstrate what they're talking about. So I just thought I would mention that. And without further ado, I will hand over to Professor Richard Holt. Thank you.
So thank you, Kath. So can I just check before I go, can you all see my slides?
Yeah.
Brilliant.
Yeah, we can.
It's always a good start when that happens, so thank you for that. Okay, so as you heard from Kath, Paul and I are going to do a double act, so I'm going to start off really giving some of the background to why this study is needed and thinking about weight management, and I'm afraid I'm going to break that cardinal rule that Kath said about obesity to start with. But the reason why I do it is that it's because some of the things that I'm going to talk about in the beginning of the talk really do very much specifically refer to people who have a BMI of greater than 30 kilograms per meter squared, which is a definition for obesity. So what I'm going to do is just really start off by talking about some of the reasons why it's important, why it's an important topic, then talk about how antipsychotics play a role in terms of weight gain, then think in terms of where we are at the moment in terms of managing weight in people with severe mental illness, and then finally just set the scene for Paul to tell us why we need the METRIC study, and then Paul will tell you some of the details of that. So if we actually look at the problem of obesity, what we know is that the rates of obesity are about nearly twofold higher than the background population among people with severe mental illness. And these are up-to-date figures from the UK, and it really contrasts with what happened in the prior to about 1960, 1970, when in fact the rates of obesity were lower among people with severe mental illness than the background population. So although the average weight across the whole population has increased decade on decade since about the mid-1950s, what we can see is that this problem is affecting people with severe mental disorders disproportionately to the background population. And the reason why it matters is it's not just the weight, it's that obesity is associated with a number of health risks, which are shown on the slide. And you can see that these are affecting many different systems. So, for example, increasing the risk of cardiovascular disease, increasing the risk of diabetes, where I'm particularly based, but also other cardiovascular risk factors. It affects the respiratory system, it affects the joint system, it affects the liver. It increases the risks of a number of different cancers, as well as having a number of fertility issues for women. So these are the physical health risks, but as alluded to at the beginning, not only is weight an issue in terms of physical health, but it also has major psychological effects, and very much aware of the issues relating to stigma and blame of people who put on weight. And this then affects them through their whole life. So people who struggle with their weight are more likely to leave school early. They're less likely to form stable long-term relationships. They're more likely to live in poverty. And in the context of people with severe mental illness, it increases the risk of people stopping their psychiatric medications. So what about antipsychotics and weight gain? So if we think about this issue of unhealthy weight among people with severe mental illness, the antipsychotics play a role, but it's not just that they're not the only factor when we start to think about unhealthy weight. So people with severe mental illness tend to have health behaviors that are more likely to induce weight gain. So, for example, we know that people with severe mental illness have poorer food choices. They're less likely to be physically active. They're generally living in environments which are more obesogenic. So, for example, living closer to inner cities where there are more fast food shops. There may also be some direct and indirect effects of the illness itself. But having said that, we know that the antipsychotics play a major role in terms of weight that is gained by people with severe mental illness. And we can see that there are differences between the different antipsychotics. So some antipsychotics are associated with more weight gain than others. So, for example, things like the drugs like olanzapine and clozapine are associated with more weight gain than certain other antipsychotics. But what we also know is that people can gain weight with any of the antipsychotics. And this is shown in this particular study that compared olanzapine with a haloperidol. So although the overall weight gain was greater among people taking olanzapine, what we also saw that even in people taking haloperidol, which is more neutral in terms of weight gain, some of those individuals gained more weight. It also depends when these antipsychotics are used in terms of their likelihood of causing weight gain. And we see there is particular issues in those people during first episode psychosis. So estimated that in the first 12 months of treatment, that people were gaining around 6 kilograms, and by 2 years of treatment, having gained on average around 12 kilograms of weight. And you can see that beyond that 2-year period, although that weight gain continues to occur, it occurs at a much slower rate than you see in those early treatments. So what can we do about managing weight? And if we look at the British Association of Psychopharmacology guidance, there are a number of things that are mentioned in that particular guidance. One of them is to consider whether we could use an antipsychotic that has a lower propensity to weight gain. And unfortunately, we don't have much evidence to support that particular treatment strategy, but there have been some studies where there has been a switch from olanzapine to either quetiapine, aripiprazole, or lorazepam that are associated with some weight loss, and also augmenting clozapine or olanzapine with aripiprazole is also associated with weight loss. But I think it's really important that we recognise why the drugs are being used in the first place, and so that any switch in drug has to take into account the mental health of that individual and other side effects that are not necessarily related to weight. So what are the other options that we have? Well, we could think about lifestyle interventions, and the sorts of things that are used in the general population are strategies to try to make people more physically active or help them to be more physically active, to eat healthily, but then to combine those dietary and physical activity interventions with psychological interventions to help people continue with their changes in health behaviour. And initially, this looked to be quite a good option. So back in 2012, there was a meta-analysis of 17 studies that had introduced lifestyle interventions to support weight loss, showing a mean weight loss of around just over 3 kilograms. But the problems with these studies is that most of them were relatively short in duration, lasting only 12 to 16 weeks, so 3 to 4 months. And of course, when we start to think about managing weight, this is a lifelong endeavour rather than a short-term fix. The other thing is that the trials tended to be relatively small in the numbers of people involved, and exactly what was in the black box of the intervention was often very poorly described. So knowing how that could be translated from one study to another was often very unclear. So following this particular meta-analysis, there were then a number of other studies that were done, much larger studies over a longer period of time, also looking to help people change their behaviours. And what we found is that when we start to look at some of the more recent studies, some of the larger studies, that promise that was seen in the initial studies was not maintained with longer studies. And perhaps we shouldn't be surprised about that, because when we start to think about what happens in the general population, we know that probably only about 2 in 10 people actually respond to lifestyle interventions. So what were the other options that have been considered? Well, if lifestyle's not going to work, what about drugs? And when we start to look at drugs, there have been a whole range of different drugs across a number of different categories that have been tried to prevent or treat antipsychotic induced weight gain. And one of the most recent meta-analyses to look at this have found that there are probably 5 drugs that show significant reductions in antipsychotic weight gain. So those would be topiramate, zonisamide, metformin, the latest GLP-1 receptor agonists, and an antihistamine, nizatidine. So there are a number of drugs that potentially could be used to prevent antipsychotic weight gain. All of these have different types of side effects and severity of side effects, and also there are differences in terms of cost. So why do we need the metric study? So Paul's going to talk about the metric study. So this is a study using metformin in people with first episode psychosis to try to prevent antipsychotic induced weight gain. So why do we need the study? Well, the first question is, why do we need to do studies in people with first episode psychosis? And the main reason for this is that most of the previous trials have focused on people with established psychosis who may be much further down their natural history of their illness, and where, as I mentioned before, the likelihood of weight gain is less than at the beginning. So if you remember, people gaining up to 6 kilograms of weight in their early parts of treatment with slower weight gains beyond. And then the second thought about it is that what we'd ideally like to do is to prevent the weight gain from occurring in the first place, rather than trying to manage it afterwards. And I'm always remembering that particular phrase or aphorism that an ounce of prevention is worth a pound of cure. So why have we chosen to use metformin? Well, a number of different reasons for this. So the previous trials have shown that there is a potential benefit for metformin in those with established psychosis. But even so, some of those trials are still quite short in duration. So we do need a longer term study to show that metformin may have benefit. The other reason for choosing metformin is that it is a very old and established drug, and the benefits that allows us is that it means that we know what the drug does, we know what its side effect profile is like, so we're not likely to have any unexpected surprises in terms of side effects when using metformin. Nextly, because it's an old drug, it is off patent and therefore is cheap as chips. So much cheaper than the newer GLP-1 receptor agonists like Wegovy or Mounjaro. And a further advantage of the metformin over those newer treatments is that it is an oral therapy rather than an injectable therapy. So with that, I'm going to hand over to Paul to tell us a little bit more about how we're going to do the study. So over to you, Paul.
Paul, just before you
yeah, I was going to say, Damien's got his hand up.
Sir,
Hi, Damien, nice to see you. Is that a mistaken hand, Damien?
Thanks. Sorry to disturb.
Are my slides there and working now?
They are, Paul.
They're working.
Fantastic. So I guess before I start to kind of talk about how clever we are in designing this trial, it's important that what we do is we highlight that actually this trial was an advertised call by the NIHR-HTA, who specified a huge amount of what we're doing. So they specified that they wanted a trial around metformin. They specified that they wanted it as a randomized trial against placebo. They specified that they wanted it a certain length of time, and we had to interpret their guidelines and put in what we felt would be the best way of managing their guidelines to turn them into a clinical trial and get a team together in order to deliver on that. And we submitted our kind of initial kind of outline application. We got through. There were other research groups that kind of applied for this. We were one of a few teams that then got invited to full trial. The HTA and their board and reviewers made multiple suggestions, which we then had to incorporate or rebuff in terms of what we could do. And in the end, our application and our grants was successful, and we were awarded the grant to deliver on this. But it is really important for people to understand that this was an advertised call from the National Institute of Health Research, who recognised that this was a priority area, that they wanted some research in this area. They previously had advertised calls for people to use the GLP-1s and actually didn't fund any of the applications there, and felt that utilising metformin was a much more kind of valuable way forward, for lots of the reasons that Richard has already kind of laid out for you. So we basically interpreted lots of the stuff that the HTA said to us, and we developed a research application on the back of that. So there may well be things that we don't always quite agree with, but we had to negotiate our way through. And there may be lots of things that people say, oh, could you do this or could you do that? And we are probably going to be hamstrung by the fact that lots of the things that we're doing in the trial were things that we were asked or told to do as part of the commissioning process. So, metric trial. Has that gone on to the next slide?
No.
No, I'm afraid not. Now it is.
Okay, so Richard's given you an update as to why we've got it. We know the issues around antipsychotics. We know the issues around weight gain leading to a whole range of issues. And you know, there isn't a weight loss medication license for people first taking them. Richard's highlighted the importance of metformin, and some small studies, and there has been a small number of studies, have indicated that they may stop or help people with their weight gain. And these smaller studies have led to a number of guidelines emerging, including some guidelines from colleagues in Ireland suggesting the use of metformin in clinical services. There is great potential, but there isn't a great deal of evidence, and particularly there isn't a great deal of evidence around prevention. So this notion of, can we actually prevent the kind of the weight gain that people experience when they first commence on their journey with early psychosis and medications, is a real untested picture, really. And so those guidelines, whilst they are interpreting some of the evidence, I think there's an element that maybe some of it's a bit premature, and that's why we need this study in order to understand whether or not this can be done in a proper clinical trial through a randomized trial to see whether or not it has any impacts. So we got a few elements to the study. We're going to look at the effectiveness of metformin to prevent weight gain, and that's very much in first episode, people, and I'll talk about that a little bit more. We have an economic evaluation. Richard's already alluded to the fact that metformin is cheap as chips. That really is very much in our favour. The fact that it's a very, very cost-effective drug, so that's good. So should help with our cost-effectiveness analysis. It's not like some of the other interventions that are introduced and trialed. I think we would suggest that if it works, it's likely to be cost-effective to the NHS. But we have a cost effectiveness analysis as part of our study anyhow. And we're also including what's called a process evaluation, because what we want to do is understand the professionals, what their kind of perspective is in terms of prescribing and kind of, getting people to take metformin, but also individuals who are part of the study, what their experiences are, and to bring that to the table. And some of that as well is going to be, well, who's going to do the prescribing? Is it going to be done in secondary care? Is it going to be done in primary care? Where are the interface issues? And just kind of having a sense of those things as well. So the process evaluation is going to be vital for us to help some of those kind of nuanced issues around more long-term kind of, uptake of this, should it work. So it's a very kind of simple, in many ways, simple trial, and it's a random controlled trial. Patients are either going to receive metformin or placebo. Obviously, placebo is a fake tablet. We've got people who are in Huddersfield who are preparing the placebo and the metformin, and those will be produced on our behalf. Obviously, it will be blinded. Neither participants or the care teams will know which treatment they've received, and that's very important. So our funding award and the abstract can be found on the link, and I think Shizana is going to send out the slide, so you'll get that link in it. But our primary objective is to test whether or not we can reduce weight gain by at least 4 kilograms, which is around about equivalent to about 5% of the expected baseline body weight. And that's going to be our primary outcome. Will it be at year 1? So we're going to prescribe the metformin and the placebo for 1 year, and our primary outcome will be at year 1. We will follow people up beyond that, and we're going to follow people up for 6 months to understand, once we stop the metformin, what happens then? Is there a rebound effect, and what's that like? And that's to understand that, many people with psychosis will take antipsychotics for a long period of time, and to give us a sense of whether or not this could be a short-term adjunctive treatment, or whether or not this is likely to be something that we need to consider on a much longer-term basis. Obviously, I've mentioned the secondary objectives, which are around economic evaluation, the process evaluation, and that's very important. It's going to be a tricky trial in lots of ways. So when I mentioned that the NIHR and the HTA specified certain things, they wanted us to start the trial early in people's journeys. And they didn't specify what early meant, but we agonized about how early is early. And obviously we want to get in there because the data that Richard just showed you about how soon people start to commence antipsychotics, but bear in mind that people with the first episode of psychosis have a whole host of the difficulties going on as well. So approaching them and starting to talk about a trial to help them with their weight gain in the midst of their emerging psychosis may well be a tricky thing to balance. We came down and we spoke to a great deal to our patient and public involvement group, and we kind of agonized about how early was early. And we came down with the fact that what we wanted to do was really start to think about, could we engage people within a month of commencing their antipsychotics? We'll obviously try and get in there as soon as practically possible. And what we don't want to do is add additional kind of stress or burden, but we also know that we need to get in there early. So we've said that we want to get people within a month of starting antipsychotics, and we know that'll be tricky, but that's what we're going to do. People will be randomized to either get the modified release metformin plus usual care, or the matched placebo. As I mentioned, we're going to follow up post-treatment for up to 6 months to evaluate the effect of cessation, and we're after 340 participants, 170 per arm, which will allow us for some loss to follow-up, and that will enable us to detect a difference of 4 kilograms between the groups. And our primary outcome is going to be absolute change in weights from baseline to 1 year follow-up. This is pretty much the pathway that people will follow. They will be consented. Treatment will be the randomized medication. Study visits will be every 3 months up until a maximum of 18 months after randomization. And once the study is finished, participants will be able to receive the results and told which treatment they received, which we think is important, and also for the care teams to understand what's happened. So all the participants will be informed, and we will have a widespread dissemination pathway. Currently, we are in the process of setup. Setting up a study, particularly a CTIMP, is pretty lengthy. It's not a straightforward process, but we are pretty much on track. We've submitted to the HRA. We've got everything pretty much in place. Our TSC and DMEC have met. We're going to ethics early February. So we're very much underway. We're hoping to start recruitment in around June of this year, and we have already had quite substantial interest from a number of early intervention teams, but we are interested in hearing from more, and I'll put up a slide with details towards the end of who you can get in touch with. We are very keen that we have a range of early intervention teams. As I said, we have already had expressions of interest from lots. Not everybody who's interested may necessarily have all the necessary kind of, things in place, such as having pharmacy in place, etc., in order to conduct a randomized trial of a CTIMP. We'll do whatever we can. We'll work with all of our study sites to see how we can kind of bring them on board. But typically, the way that research goes is once you start to research an area, those people are either magically cured or disappear. So you can never have too many sites. So if you're interested, please do get in touch. We anticipate that if all goes according to plan, we'll finish our kind of study, and that will be round about November 2028 that we have our last participant having their data collected, and then we will do all of our kind of analysis, and we will be publishing hopefully early into 2029, and 6 months would be May at that point. We've had lots of patient and public involvement right the way throughout, from the initial not just even thinking about our first grant application and the kind of first thing we did, right through to the full application. They've been part and parcel of all of our work in terms of thinking about consent to treatment forms, everything that we've done to date. So our PPI have been totally involved. They've reviewed all of our documents, participant engagement, newsletters, etc. And what we hope to do is ensure that our PPI involvement group advise on future engagement, review other documents, and review our results and summaries, and kind of give advice on how we communicate that through to the kind of the wider kind of network of people. So if you are interested in being a study site, I think Radwa may well be here. Radwa very kindly has been kind of leading with Richard and myself on reaching out to sites, etc. But we'll kind of, this will be included in the documents that goes out to you. But please do get in touch with Radwa and send her an email. She'll send you a form that will give us some basic information, and please do reach out, because we'll be very keen for you to get involved. Stakeholders, obviously it was funded by NIHR. Pennine Care are the sponsor for this. We're very grateful for the support that we get from the trials unit at Sheffield, who are, been really great at working with us, and also at Manchester University, who are leading on the interview study. I'm delighted to be working on this with Richard. I got to work with Richard on the stepwise study, and we kind of did lots of work there. So it's great to work with Richard again. Venu's our PPI lead. Huge thanks to Hannah, Sienna, and Radwa, who are our trial managers, who do all of the background work. And Richard Kears is leading our interview process evaluation. And I think that's probably me, and over to questions. Richard, anything you think I should have added alongside that before I hand over to Damien for his hand up? If it is a hand up question this time, Damien.
Well, no, I think that was great. I think you've pretty much covered everything.
Cool. Cass, should I let you manage the questions?
Yes, so who's first? Thank you very much for the presentation. And just to let you into a secret, I'm actually a co-applicant on the trial as well. So I've got a few questions up my sleeve, but we'll see what comes from the audience first. So Damien, you're number one, Damien Longson. Say where you're from. Say where you're from, if you can.
Yes, Damien Longson, Greater Manchester mental health psychiatrist. Thanks very much, Paul and Richard. That's really interesting. I think we'll get to the point where we're putting aspirin, statins and metformins into the drinking water for everybody. I think that's going to be the way. And I think this is a great study because I was involved in a GLP-1 application, which, like you said, Paul, they weren't successful. And it's probably because it costs a fortune, the GLP-1s, and they're hard to use. So this is a bit of a no-brainer, really. My question is, we know a lot about metformin in older, overweight, diabetic people, but what do we know about the side effects of metformin in 18 to 20-year-olds whose blood sugars are normal and so on and so forth? I mean, are you anticipating a different side effect profile in that young, otherwise healthy group?
Do you want me to take that one, Paul?
It sounds very much up your street, Richard.
It sounds a little bit up my street. So thanks for that question, Damien. So I think a couple of things really to say about that is that firstly, we are seeing an increasing number of younger people with type 2 diabetes. So we are seeing people even in childhood who are using metformin. So we have an increasing experience of using it in younger people. Also, it has been used in people without diabetes as a mechanism of trying to prevent diabetes. So it was used in the Finnish diabetes prevention program and also the American diabetes prevention program. So in people without diabetes who have normal glucose levels at the time, without any suggestion that it would cause hypoglycemia or glucose levels going too low. And the side effect profile that we saw in those studies were very similar to what you'd see in people with diabetes. So the main side effect being gastrointestinal side effects, which is part of the reason why in the trial we're actually going to be using a titration approach. So starting at a lower dose and gradually increasing doses every couple of weeks to get up to a therapeutic dose, but also with an option of reducing the dose back down to the highest tolerated dose rather than having a forced titration process. So I don't think that we're going to see any unusual side effects in this group. As another parallel, it has also been used to address, in a small number of studies, steroid-induced antipsychotics. So again, steroid-induced weight gain. And in those individuals, again, no unusual side effects appearing at that stage. So I'm not expecting that we'll see anything that we haven't seen already.
Thank you very much.
Nicola, you're next.
Oh, hi.
Nicola Murphin, hi.
Hi, yeah. I'm Nicola from South West Yorkshire Trust. I suppose my question is, sorry, I'm Senior Clinical Research Officer, and I'm just wondering, because there's a lot of organisations on as well, the usual care process in each area will be slightly different. And in some cases might not be what it would normally be, just due to the sort of stretch on the staffing and things like that. So I suppose I'm just putting that out there, not particularly just as a question, but is this something that you've kind of anticipated and brought into the sort of protocol of how we would manage that?
Should I go for that?
Yeah, you go for that, Paul.
Well, I guess it depends how much you're saying you're diverting from usual care. This is very much about an early intervention in psychosis. study. So we're recruiting from EI teams. So if you don't have an early intervention in psychosis team, then that's too much of a drift.
Sorry, probably not. Yeah, we do. What I'm saying is, within that team, if their usual care is not particularly what's in the protocol or what you would be sort of anticipating, that sort of I suppose literacy around good health and diet and exercise isn't within that usual care process. I guess I'm just putting it out there as a what would that, how would that affect it?
Well, I guess that's kind of where I was going to go on to. That obviously we have some certain parameters that we can't go outside. So if you're a trust that doesn't have an early intervention in psychosis team, then we can't go to you. And we also know that early intervention in psychosis teams differ quite radically. I was the clinical advisor to National Audit of Psychosis for a number of years, and we focused on early intervention teams. So we know that there's a diversity of what early intervention teams offer across a whole range of things, you know, from cognitive therapy through to dietary and lifestyle advice. So we're going to use some of that data to give us a sense that actually what we need to do is, this is a pragmatic trial, and we know that there will be differences, and we will look at those differences. Now, if you're not doing anything, that's probably not going to be great, and hopefully you're doing some work towards managing people's kind of, you know, diet. But we will be looking at what treatment as usual actually means in each of those, and we've got a sense of that through the audit already. We already know that treatment as usual varies to a certain degree across teams, and the data is at individual trust level, so we've got a sense of that. So we can allow within a pragmatic trial for some differences. That's absolutely fine, and especially with the randomization, we know that should be okay too. But you do need to have some of the basis of an early intervention team that's within certain parameters, and we ask for some of those things within our expression of interest. And if you go too far beyond some of those parameters, I'm afraid that we'd struggle to take you as a site. But I don't think there's any that we've seen so far that have come from expressions of interest where we thought they couldn't be involved as a site because of the slight differences of their provision in early intervention psychosis care delivery.
Yeah.
Or could I just also add to that and also give you reassurance, Nicola? I mean, I think we accept that there are going to be differences across different sites, and you know that's just the fact of life. But you know, the way that the trial is set up is that the only differences that we're wanting to look at within each and different sites is whether it's possible to add the metformin to whatever people are doing, and then we can take into account some of those some of the other differences that you describe when we do the analysis of the data.
Yeah, thank you.
Thanks for that question, Nicola, and for the answers. Susanna Mills, you're next.
Thank you very much for sharing that very interesting presentation. So my name is Dr. Susanna Mills. I'm a consultant in public health at Cumbria Northumberland Tyne-Aware Mental Health Trust, and also a researcher at Newcastle University. You alluded to part of my question already, but just to kind of explore it a little bit more about other age groups who might potentially receive metformin. So whether or not the age range might be applicable even lower. So if we're thinking about more perhaps 14, 15, 16 age groups. I know it's perhaps more exploratory, but whether you think the rationale might probably be the same in terms of the physiology and therefore the applicability, whether you think there's the likelihood of that, you know, spreading further.
So, Susanna, I mean, again, a really, really good question. And we thought long and hard about how to actually address this. Of course, if you start to do research in children, it becomes a completely different and more complex problem. In terms of service organisation, obviously, you're then looking at CAMS mental health services rather than adult first episode psychosis services, which again adds a further complexity, which is part of the reason why we are not involving people under the age of 16. But in principle, I think that what we would expect to see in those that are 16 and above will be similar for those in their early teens as well. But just for logistical reasons, it wasn't possible to include a younger group. I mean, Paul, do you want to come and add to that?
I guess just to add that actually the original call did say 18 years, and it was us that pushed it down and said actually we'd like to go down to 16. We felt that with the resources that we had and where we're at, we couldn't go any lower. But it was us as researchers that pushed the NIHR to say, well, could we go down to 16 rather than 18? Because of the very important issues of kind of seeing whether or not this could be applicable to younger people, really, Susanna. But that was as far as we could push it, I'm afraid.
Well done for getting it that far. Yeah, thank you.
You're muted, Kath.
Catherine, I think you're still on mute.
I'll dive in with a question if there isn't any. So one of the things, or one of the issues, or one of the popular things perhaps at the moment is that people may start off their own accord if they want to lose weight. They may consider buying medications to help with losing weight if they're not eligible perhaps in the NHS. And I just wondered, perhaps I know the answer to this, but I thought it was an interesting question. In our trial, if people decide to start taking, who are eligible for example, the GLP-1s type of medications and the GIPs, what would happen? Would we allow that during the trial, during the year? Or is it something that we're telling patients that they couldn't start that? Richard or Paul?
So, I mean, Kath, obviously that is an issue, and we have considered. I don't think we've come quite down to an absolute decision about that, but I mean, I think there are a couple of things to say. I mean, obviously, this trial is designed for weight gain prevention, rather than treatment of obesity. So the numbers of people who will be already eligible for GLP-1 receptor agonists within its license, I think will be actually a small number of people. So I think that's the first thing to say. Of those people that are eligible, you then have to say, well, if they're not going to be having this funded by the NHS, it's going to be self-fund, and that's going to be, as you're probably aware from the national press, that is a significant sum of money that people are actually being asked to spend on weight management drugs, and therefore that will also limit the number of people who will have access to that treatment. So I think that probably there are fewer people that would affect than if we were going to a population of people with established psychosis or people without psychosis. But I think it's taking a GLP-1 receptor agonist is an exclusion criteria for the study. So if they did, and we will be recording medication, it would mean that they would not be eligible for the study beyond that, and therefore would not be analysed as part of the per protocol study. Although I think we will probably still include them in the overall study. Paul, is it?
Yeah, I think that's currently the state of play, how we're managing this, Kath.
Thank you.
Okay.
Yeah. So thanks for that. That's I'll just another question is, so will metformin, this study is successful in terms of the outcomes, will that mean metformin gets a license for this indication?
So I mean, my view about that, Kath, is I think it's unlikely it will get a license because there's probably no commercial incentive for a pharmaceutical company to go and add this particular license. There are lots of other situations where metformin is also used, where it is not in license for the very same reason. But what I would hope is that if this study is successful, that it will be then included within NICE guidance. And just to give another example, metformin is recommended with NICE as a treatment to prevent type 2 diabetes as well as treat type 2 diabetes. But again, that didn't come in its initial licensed indication.
Thank you. Thank you.
We'll just give Damien a load of stock to put in the water supply.
Susanna, do you have any other questions or comments?
I don't have any other questions or comments, but if anybody else does, please do feel free to add it in the chat or raise your virtual hand. We still have 10 minutes left. If there aren't any more questions, then we're happy to give you the gift of time back. But I'll give it another second. Yeah, Sarah.
Hi, hopefully Paul and Richard know me. I'm the pharmacist for Pennine Care that's actually involved with metrics. So I just something has just dawned on me that hadn't actually dawned on me prior to the presentation. So thank you for providing the presentation because it's been helpful to me. You're talking about the fact that the study is a 12-month study. The individual have metformin or placebo throughout the 12 months, and then there's a 6-month follow-up post that period of time to actually look at whether there's like a rebound. I just wanted to clarify, when we're actually consenting individuals initially, are we saying this is an 18-month period so that they are actually consenting to having 12 months of the trial, then 6 months of nothing? Because the person at the end of the 12 months may have realized that they've not gained weight, and they may want to continue on the product that they were taking at that point. And I just wanted to check that consent issue and how we're managing it.
So the answer is yes, we are consenting people for that time. There is a slight caveat for that, Sarah, is that so that we don't actually run the trial for 18 months for everybody. For those that are recruited in the last 3 months of the study, they will only have a 15-month trial period, so 12 months of treatment with 3 months of follow-up. So the rationale for it is that at the moment, we don't know how long people need to stay on metformin. It may be that they only need to stay on metformin for a year. And unless we actually have that period of off treatment after that initial year, we don't know. And it may well be that people do need to be on indefinite treatment, but unless we have that stop to see what happens to weight, we will never know the answer to that question. So that's the rationale for having it, and we will be explaining that to the participants during the consent process.
That is absolutely in the consent form, from what I recall, and was discussed with our patient and public involvement group.
Thank you.
Right, thank you. Thanks, Sarah. If anybody has any reflections or Paul?
Just wondering if there's anybody who's here who may be from a site that might be interested. If you have any questions or any thoughts.
Or if you want to message us, we'll share the details in a follow-up email anyway.
Paul, I've got a quick question. Sorry, it's Damien again.
Damien,
Just
yeah.
You've done lots of research, Paul, and you've got a sense of how hard or easy studies are to recruit to. I can't recall seeing the inclusion-exclusion criteria, probably because I haven't seen them, if you've not got rec yet. Do you have a sense that this is going to be a difficult, because it could be a high volume study, actually could be fairly straightforward to recruit to because of our services are rammed, and unless you've made it really difficult to get patients in, it should be a fairly straightforward, good for you, do you want to come on this trial, no brainer. But are there any hidden corners that will make this difficult?
Well, I mean, as you said, David, I've done lots of clinical trials, and one thing that we know is it's important to make it easy for people to get into studies. This is a pragmatic trial. We want to make sure it's representative of a wide range. So we've absolutely not put any kind of hidden things in there. Our exclusion is fairly minimal. We actually were wanting to exclude a group of people who, pregnant women, and we were keen to exclude those individuals from the trial, primarily because they would put on lots of weight. But actually, we were advised by the HC that wanted to keep it pragmatic, keep it as open as possible, and they said, no, we want you to include pregnant women. So there are absolutely no hidden kind of exclusions that you would be surprised by. All pretty standard stuff. So it's also very much of its time, I think. I think people are really interested in this question. I think I mentioned that there are already guidelines emerging saying you should be thinking about this clinically anyway, but the evidence is pretty limited. So this is a great way of clinicians getting involved, thinking about this, starting to consider prescribing, but as part of research studies rather than just through their own clinical work. So I think it's a very, very timely study. So it should be relatively straightforward, but I hate to jeopardize our ability to recruit and yeah, absolutely knock on wood. Who knows, David? Who knows? But it should be, and we're absolutely not putting anything there that's going to trip anybody up or make it difficult. We try to make it as easy as possible. I think the only tricky thing is going to be about that trying to get people in the first 4 weeks of their antipsychotics. But even that, we think about all sorts of trials that are run in A&E, that are run in surgery, where people have given hours to think about whether they take part in a study. Oftentimes, kind of with life-threatening issues, and people can recruit there. So 4 weeks, I'm sure that we can recruit a sufficient sample.
We just to add to that, Damien, we also have provisions around people's capacity to take part, and obviously that's one of the potential issues if you have people right at the very beginning of their psychosis, and that was part of our rationale for extending that window to start the metformin up to 4 weeks after starting the metformin to sort of hopefully allow people who very, very seriously ill to regain enough capacity to take part in the study within that window.
Great, thanks. There was a question, but I think it's been answered now in the chat around who to contact. So I'd like to get our R&D team involved. So Daryl, I think we've got back to you on that if you're happy with that. Otherwise, I can share the details in an email to you as well.
Yeah, that's great. Thank you so much.
Thank you. So if we don't have any more questions, then if everyone's happy for me to wrap up, I just want to say a massive thank you to Catherine, Richard and Paul to share insights of their study and tell us more details about that as well. It's really great that you're adding to that kind of, evidence-based around preventing weight gain as well for people living with severe mental illness. So we look forward to hearing more about your study as it moves along, and anything that we can do to support it as well in sharing, disseminating some of the findings or anything like that, we'd be very happy to do that. So thank you. Thanks to everybody else as well for joining us today. Apologies again for the communications around the starting time, but I'm glad to see so many of you still here and were able to join us. We just want to share a little survey, if you don't mind. Jess, we're always looking at ways on improving the way we deliver our webinars, so please could you submit your feedback via this form that I'm just going to include in the chat, and then say another final thank you to our speakers, and hope you all enjoy the rest of the afternoon.
Thank you for inviting us.
Thank you very much.
Thank
Thank
you.
you very much,
Bye-bye.
Mr.
Thanks, everyone.
Thank you.